Hello, hello, everyone. Thank you so much for joining from different parts of the world. We do have Vinny, who's going to be doing the teaching point, and Mo, who's going to be presenting the case to Dr. Jason Ryan. And he's none other than the creator of Boards and Beyond. Many of you might have known it and used it prior. And we also have Glenn, who's a new member of the Academy, who's going to be doing the amazing job of scribing. Before I do give the Glenn to share his screen and for Anmol to start scribing, Dr. Ryan, would you like to introduce yourself?
Sure. Thank you for having me. I really appreciate this opportunity. I've done a number of these podcasts and webinars, but this is going to be super fun to actually hear a case and talk about it with all of you. I think you may or may not know me from Boards and Beyond. That's my website. It's an educational tool for step one and step two. I started it over 10 years ago, and it took a long time, but it grew and grew and grew. And I sold it a few years ago to McGraw-Hill, the company where I work now. And it's been such a treat to launch that company because it's grown beyond my wildest imaginations. I never thought so many students from around the world would use my videos, and I'm very fortunate to get to interact with all of you. So thank you for having me here today, and I'm very excited for this case.
Anmol, do you want to say a few words before you start presenting the case?
Yes. And first of all, it is our honor, and thank you, Dr. Ryan, for accepting our invitation. And I would wish a very good morning, good afternoon, and good evening to everyone across the globe. My name is Anmolpreet Kaur, and I am an MBBS graduate from Government Medical College, Amritsar in Punjab, India. I am just another fan of Boards and Beyond, and it has helped me a lot in my journey. I still have all the videos, and I've been a member of the Clinical Problem Solver since 2023, and it has been a great journey. It has and is continuing to make me a good physician, and I hope to become an internal medicine resident one day and fulfill my dream. Currently, I'm working in a cardiology emergency for 8 months now. And the case I'm going to present today, I just saw 15 days back while we were deciding that Dr. Jason Ryan is coming to discuss the case. And I just compiled the case and we'll be presenting that to you. And it's a big honor for me. I will always cherish this moment. Looking forward to the next 1 hour. Very excited and equally nervous.
Oh, don't be nervous. This should be fun. I'm really looking forward to it.
Thanks a lot, Anmol, for the amazing introduction. Glenn, whenever you're ready, would you like to share your screen?
I will start with the case. And regarding my case, I have divided it into 6 aliquots. So I will pause after the aliquot and then we can discuss what is the progress, what we're thinking about it. So I'll start with the case. My first aliquot includes chief complaints and a little bit of the HPI. The chief complaint of the patient was shortness of breath for basically 1 month and cough for 2 weeks. A little bit about HPI is a 37 years old female who presented to the cardiac emergency of a tertiary care hospital with the complaints of shortness of breath, which had been present for 1 month but worsened in the last 7 days. The dyspnea exacerbates in supine position and improves on sitting. There is no history of any recent fever, but it is associated with a dry cough, which occurs when the patient inhales deeply. The cough is not productive and is present for 2 weeks. On arrival to the emergency, the patient is experiencing shortness of breath in resting position. I'll stop here.
Okay, very cool. This is a young person, right? So as a cardiologist, like 37 years old is a baby. Most cardiology patients are 70 or 80 or 90, or I even had a few in their hundreds. So right away, that makes you worried because, I mean, you don't want to miss anything serious in anyone, but especially in a young person, these are people who are healthy and many years of life ahead of them, and you absolutely don't want to miss any important diagnosis. The differential for this is massive. Shortness of breath that gets worse when you lie flat can be heart failure, but that is a non-specific thing. And I've seen people with pneumonia and upper respiratory infections, and their shortness of breath changes with position or something like this. So that in and of itself doesn't tell you a lot. And then you may be holding this back, but a huge thing here would be to know if there's any history that she had before this. Even though she's 37, does she have any diagnoses like type 1 diabetes or a family history of something along these lines? And then the diagnosis for this is so broad that, when people present with this kind of complaint, they usually immediately get tests like chest x-rays and EKGs and things just to oxygen saturation, just to quickly see how serious the situation is. Someone with a normal EKG and normal vitals who has shortness of breath is very different from someone who has a pulse of 120 with shortness of breath. That's a huge red flag.
Yeah, that's amazing so far, Dr. Ryan. So if you had two symptoms like shortness of breath and cough, how would you prioritize and which one are you going to be more worried about?
I mean, I think the shortness of breath is more worrisome, but many causes of shortness of breath go with the cough. A cough also, we think of that sometimes as a respiratory complaint, but you can see that in pulmonary embolism. People can have a cough. People can have a cough from heart failure. People can have a myocardial infarction and have a cough from some pulmonary edema from that. So that doesn't really help you too much to say exactly what it is. Hopefully those two complaints go together, and whatever we're going to discover is going to tie them together, and that we're not working up separate things here. So I think the shortness of breath probably takes priority over the cough, but I would kind of think of them together and just start looking broadly for things that can cause general respiratory compromise and shortness of breath and cough together. And obviously focusing on the most serious things first. So could she have a myocardial infarction? Could she be in heart failure? Pulmonary embolism is not impossible in this situation. All sorts of pneumonia and lung pathologies and things like that are also possible.
Wonderful, wonderful thoughts. I will continue with the history of present illness. The patient was apparently well until approximately 2 months ago when she noticed progressive dark discoloration of the face. Initial evaluation at an outside facility attributed this to anemia. Around the same time, she began experiencing menstrual irregularities characterized by increased frequency of cycles, twice or thrice within a 28-day interval, along with episodes of whitish, foul-smelling vaginal discharge. Over the next few weeks, she noticed intermittent generalized body aches, and 1 month prior to presentation, she began experiencing intermittent lower abdominal pain and progressive shortness of breath. Initially, the dyspnea was present on exertion, but it gradually progressed. A chest X-ray was done at that time. It revealed pleural effusion, and a diagnostic pleural tap was also performed at that time. Pleural fluid analysis revealed an exudative infusion, which was lymphocyte predominant with elevated LDH and low glucose. The patient was then presumptively managed as a lower respiratory tract infection in an outside facility with antibiotics. Despite this, her shortness of breath continued to worsen, and the patient developed dyspnea in lying down position and had her sleep affected for the last 1 week. And on arrival to the emergency, she was dyspneic even in the resting position, requiring oxygen support. And to clarify, the patient has no past medical history except the recent symptoms for 2 months. And the current medicines, the patient was basically taking acebrophylline 100 mg twice a day, and montelukast and fexofenadine. That is just for the recent symptoms. No chronic medicine, no chronic past medical history. Family history is not significant, no significant cardiac or any other history. And the lady has 3 live children, which is normal. So the obstetric history is normal, and there are no known allergies. Regarding the social history, there is no history of any recent travel. The lady does not drink alcohol or smoke. There is no known animal exposure, and the patient comes from a rural area in northern part of India.
So
So,
there is a lot of information which
yeah.
Anmol has shared, and I'm just going to summarize that's what we have heard so far to make it easier for you, Dr. Ryan, and for us, everyone else to also process it. So this patient is a 37 years old female who's been having shortness of breath for 1 month and started having cough 2 weeks ago, and she had this cough shortness of breath is worse when she is in supine position, and she had similar complaints like 2 months ago with discoloration of her face, and she was diagnosed to have irregularities in her period, and they attributed it to anemia. And she has no significant past medical history, and she has 3 children alive and normal vaginal delivery, and she is from northern part of India.
And when you say discoloration of the face, do you mean she was pale and they attributed that to her anemia? Is that what you mean?
Actually, she just said that she was more hyperpigmented than usual, which was,
Hyperpigmented.
yes.
Okay.
And they thought it was, the family thought it was due to anemia because she's having menstrual irregularities. And the outside facility, they only evaluated her for shortness of breath. And basically, it was thought to be anemia, but it was progressive hyperpigmentation of the skin.
Yeah. Interesting. Okay. Yeah, that's a little bit confusing, and it's like this is not your fault. The histories are like this, right? People come in and say things that don't make sense. I can think of two ways your skin can be discolored related to anemia. One is if you're hemolyzing and you're jaundiced. The other is if you're just anemic and you're pale. If they attributed this to menstrual irregularities, you would think that they were thinking that her change in color of her face was paleness due to anemia. That's why I was asking. But it sounds like it's not clear. This is what she recalls them telling her. And so you just have to go with that. And this is the way medicine goes, right? People aren't doctors. And so they come to us with information that doesn't add up with what we know, but that's what they were told. So let's accept we know that there's some discoloration of her skin. Um, and is the anemia confirmed, or were there lab results, or is this just something she recalls someone telling her?
I believe the dark discoloration, which she said in a layman language, was actually due to anemia at that point of time because she was bleeding a lot. But just that was the complaint she presented with. Yeah.
Yeah, yeah, okay. And then people are mentioning in the chat, adrenal insufficiency, which, when you say hyperpigmentation, that's what people think of. Um, this would be a really weird presentation for adrenal insufficiency. Usually, it presents with, amenorrhea. You lose LH and FSH function. Usually, it presents with, GI symptoms, nausea, vomiting, things like that. Shortness of breath that's positional, and anemia. I mean, cortisol can do everything, right? So adrenal insufficiency or Cushing's, who can say? But that, to me, as a cardiologist, that would be a really strange way for an adrenal problem to present like this. Um, so, yeah, putting it all together, which you did a nice job, Kuchal. There's a lot of strange information here. We've got cough and positional shortness of breath, and then a history of bilateral pleural fusions. Is that correct? You said?
It was mostly left-sided pleural effusion.
Hmm. Okay, and they tapped it, and it was exudative. Is that right?
Yes, it was exudative lymphocyte predominant with raised LDH of around 569 with
Hmm.
serum LDH of 133.
Hmm. Okay. Very interesting. Yeah, I'm stumped. I can't tell you what this is. If one of you guys knows it, put it in the chat. I'll tip my hat to you, but there's a lot of information here. Love to hear more about a physical exam and, some labs to see where things are right now. and we'll try to fit it all together. And yeah, that's a good question. Someone just asked, when was her last delivery? You said she has 3 children. I assume those were all a while ago, nothing recent, or you would have said so, but just asking.
That was a while ago, 5 or 6 years back. Okay, I will progress to the vitals and the labs, initial labs for the further case. At the time of presentation, her blood pressure was 120/90. Heart rate was 118 per minute. Respiratory rate was 26 per minute, and saturation was 94% via nasal prongs. She was afebrile at the time of presentation, and general appearance was a sick-looking lady. She was conscious and oriented. HEENT pallor, we can say pallor was present. Pupils were normal, bilaterally equal in size and reacting. Jugular venous distension was present. No evidence of icterus with normal conjunctiva. And the cardiovascular exam, soft heart sounds, S1, S2 heard. And as we said, the JVP was raised. There were no murmurs which were appreciated. In the pulmonary exam, bilateral air entry was decreased. It was more decreased on the left side. Abdomen was mildly distended with mild tenderness present in the upper abdominal region with no rig-bound rigidity. Neuro exam was within normal limits, and extremities along with skin was normal. So I'll just repeat. We had the patient with tachycardia and jugular venous distension. And in the labs and imaging, the HP was 11 with an MCV of 84.8. TLC was 8100 with normal differential. Neutrophils were 70.5%. Regarding the platelets, they were 3,44,000. And the serum electrolytes were within normal limits. Sodium 139, potassium 4.14, chloride 104. RBS was normal as well, 101. Then we had BUN of 11, creatinine 0.49 normal, serum LDH of 133. Total serum bilirubin was normal, 0.72. AST and ALT were normal as well, AST being 14 and ALT being 9. Serum total protein was slightly decreased at 5.8, and albumin was 3.5. Alk phos was 94, and total cholesterol was 133. Viral markers were sent for hepatitis B, C, HIV, and the patient was non-reactive. I'll stop here.
So Dr. Ryan, there's just a lot of information which Anmol has presented. And when you have something like this, and especially if a person is from northern part of India, and how would you separate what's noise and what is the information which are you concerned about for your diagnosis to come up with? I think you're muted.
Oh, sorry about that. Good question. So I would say in the modern era, it's more normal to have too much information than too little. A lot of times, most of the patients I see, especially if they're being presented at morning report, and they've gotten through multiple levels till they get to a consultation or something, have an overwhelming amount of data. So a huge skill to hone as you practice is how to distill data down to the key points. Some things that jump out at me. She's tachycardic and tachypnic. Those are really important things to not miss. I mean, these are how big mistakes get made when somebody says, well, it's non-specific chest pain. You don't like to ever say it's something benign when someone has abnormal vitals. So there's something real going on here. Not that we doubt it at all, but the vitals definitely show you that there's a real pulmonary process going on here. And then there were a lot of labs you listed. A lot of them were normal, like the lights and the belly labs and all that. Can you say again what the white count was and the differential? I missed that, or I can't remember what you said.
The white count was 8,100 with normal differential count.
8,100. Okay, so the white count is not elevated by your standards, correct there, and a little bit of a left shift. Is that right?
Yes. All the labs are pretty normal, except that we have a little hypoproteinemia.
Yeah, a little, yeah. Interesting. Okay. And on exam, the major findings are the decreased breath sounds and some jugular venous distension. Is that right? There were no heart murmurs or extra heart sounds or anything like that?
No, the S1 and S2 were soft, quite distant, and we had JVD with tachycardia and
Mhm.
tachypnea.
Yeah. And how big a person is she?
She, I would say her BMI could be around 28.
Hmm. Okay. All right. So, distant heart sounds are really common in obese people, and there's more of that, at least in the United States. But she's not obese. And, when you don't hear heart sounds very well in someone who's not really overweight, that's something that is concerning. So, it sounds like there's some kind of fluid collection going on in the lungs, maybe on the left side, maybe a pericardial effusion too. Uh, an X-ray and an EKG are going to be very helpful. And if someone has a good idea, please share it in the chat. But I don't have a clear idea of what's going on right now based on the information we have so far. Still a lot of disparate facts that we're trying to tie together.
So, Dr. Ryan, so if you have a patient who is presenting with like 28 is a BMI and her JVD is higher side and there's decreased breath sounds on the bilateral lung, and what her complaints is shortness of breath, and she is postpartum with 3 children, are you concerned it's to do all her symptoms that are to do with the lung, or it's to do with the heart, or
JVD is usually a cardiac thing. That's a filling defect of the right side of the heart. There's some elevation of venous pressure. So, the fact that you see JVD and she's short of breath when she's lies flat, that's starting to paint a picture of someone who's volume overloaded. Um, Volume overload can be secondary to something else going on, or it can be primary from left ventricular cardiomyopathy, from right ventricular failure. So early to say exactly how it ties all together, but you make a good point. There's evidence of fluid overload here for sure.
Anmol, we are ready for the next aliquot whenever you are.
Wonderful points. I'll just share the ECG with you all.
Okay, what do you guys think?
Um, this was mostly, we thought that was sinus tachycardia on the ECG.
Mm-hmm. Yeah, the voltage is not huge. I wouldn't, it's a little on the low side. And again, that fits with some fluid. It could be a pleural effusion, it could be a pericardial effusion, but if you told me she had a pericardial effusion or pleural effusion with this EKG, I wouldn't be surprised. Other findings of PE or pleural effusion, so you look for electrical alternans. There I wouldn't call this electrical alternans. There are some random QRSs that are a little different from others, but I don't think there's definitely alternating back and forth. So if you don't know, electrical alternans is when the height of the QRS complex changes from one beat to the next, and it happens when the heart swings inside a fluid-filled sac in a pericardial effusion. I don't think I can say that's here. A lot of these QRS complexes look the same. There's some random ones that look a little smaller than the others, but I wouldn't call it alterans. I would say the voltage is kind of on the low side. I mean, other than lead V2, none of these leads have much voltage, more than a few millimeters. And so this does look a little, that with the distant heart sounds makes me think there's probably some pericardial fluid. The thing is, you can get pericardial fluid when you're sick for other reasons too. It doesn't necessarily mean your primary problem is pericardial effusion. You can have sepsis with pericardial effusion. You can have a flare of lupus with pericardial effusion. So, there's a lot of evidence here pointing to something going on with the heart, but I'm still trying to find out, is that the primary problem or is there something else going on here, and the heart is getting involved? And so more information will be helpful.
We also have the chest X-ray for the patient.
Okay, what do you guys think?
We have a left-sided pleural effusion, and we have cardiomegaly as well. I think this is after the procedure. The chest X-ray is after the procedure. We did some
Okay.
procedure for this patient.
Okay. Yeah, it looks like there's a catheter or something there. There's a lot of stuff on the chest. Heart's big, and there's pulmonary edema.
Yeah. So a focus echo was done for this patient, and it was found that she's having pericardial effusion.
Anmol,
And
by any chance, do you have an X-ray prior to the procedure so everyone
no,
could see what? Okay. And what
yeah,
procedure was done for the patient again?
I will share that now.
Keep it you can keep it a secret as long as possible.
So the patient was found to be having pericardial effusion with the right ventricle was collapsed, IVC was dilated, normal left ventricle size, systolic, diastolic function, ectopics and tachycardia was noted during the study, and the patient was found to be having tamponade physiology on the focus echo. And for
Okay.
that reason, pericardial tap was done and pigtail catheter was inserted. That was what I was mentioning.
Yep. And can you guys see the catheter there? The pigtail catheter. So a pericardial effusion would definitely explain a slowly developing pericardial effusion could explain a month of shortness of breath and some cough and some shortness of breath that's worse when you're lying flat. All that sort of fits. I cannot, for the life of me right now, tie that in with skin changes, anemia, and increased menstrual periods. Tying that together with the pericardial effusion is tricky unless you start to think about something systemic like lupus or rheumatoid arthritis or something, that's affect even those things. I mean, for those things to lead to menstrual irregularities seems a little bit far-fetched to me. Again, someone mentioned Addison's disease. I still find that hard to fit together. So uh, it's great that we identified her pericardial effusion. It's glad we're going to keep her from dying from this with a pericardiocentesis, but I don't think we've solved her problem yet, in my opinion. There's still more to it.
Yes. So the pericardial tap was done and the fluid was found to be straw colored. Amount of fluid removed was 150 ml and we inserted the pigtail catheter. We also got the pericardial fluid analysis. The fluid cytology had RBC count of 2000 and TLC of 750 with MNC percentage of 60% and neutrophil percentage of 40%. The fluid biochemistry was the pH was towards the normal side of 7.5. Glucose was also towards the normal side of 85. Proteins were 4.3. Albumin was 2.75 with amylase, lipase 8 and 3 respectively. The LDH of pericardial fluid was 266 and ADA was 51.6. So we got the automated culture for the pericardial fluid, which showed no growth. Gram stain also revealed no microorganisms. Fungal smear showed no fungal elements. ZN staining was also done, which for acid-fast bacilli, but no acid-fast bacilli were seen. And CB-NAT test was also done, and Mycobacterium tuberculosis was not detected. These are pretty common tests we send in India because TB is very prevalent here.
I bet. That makes sense. Yep.
Yes. So should I continue further?
Sure. Yeah.
But
Just
yeah, why don't we?
summarize
I
the
just
key
have one
findings.
question before we continue, if that's okay with you, Dr. Ryan.
Please.
Yeah, so there is a pleural fluid analysis which we have from the past, and would you be concerned and would you try comparing it with the pericardial effusion which the patients had at the present admission, or would you think of it as two independent events which has happened? In your head, how are you processing all that information?
My gut tells me they're probably related. Uh, and that's why there were a lot of details given of the pericardial fluid, but I wondered if you could highlight what the key, you mentioned a lot of things that were pretty normal, but what were the key abnormalities you found in the pericardial fluid?
Yes, the proteins were 4.3 and the LDH was 266. So the serum LDH was 133. And so accordingly, this pericardial fluid was exudative as well. If we apply all the criteria, so the glucose was normal, proteins 4.3 and LDH 266. Yes, and slightly TLC was 750 with the MNC percentage of 60%. These were these were the abnormalities.
What's TLC for? What is that total?
750.
Total.
What does it stand for, TLC? I'm sorry, I'm not familiar with it.
Oh, total leukocyte count.
Leukocyte count. Gotcha. Okay. All right. Gotcha. All right. Very interesting. Yeah, I don't have a good way to put all this together. I suspect those, people that are collecting fluid in their pleural space and pericardial space always makes me think there's some kind of systemic inflammatory thing going on. And so I have a feeling those two are related. It could be cancer. It could be cancer that spread to the lungs and to the heart, could cause effusions in both places. It could be an autoimmune inflammatory process involving both places. But my hunch tells me, that those two things are tied together, that there's a reason she's collecting fluid around her heart and around her lungs. The Lights criteria for transitive and exudative were developed for pleural effusion, so they don't really apply to pericardial effusions. Although we just can say that the fluids, both types of fluids she has, look similar, in their content and makeup. So that in and of itself is interesting. I don't know that it tells us anything about the mechanism of her pericardial effusion, but something is causing a lot of inflammation of the pleural lining and the pericardial lining. That's the way I put this together. And I'm trying to think of what that could be. TB is a great thought. TB can do everything, but so far we don't have a lot of great evidence for TB. But it's a notoriously difficult diagnosis to make, so I don't ever consider it totally ruled out, especially in an endemic area of the world.
Yeah. Yes, and the ADA was 51.6 in the fluid, the normal value of which is greater than less than 40. So when it is around 40 to 60, we have to suspect TB in that patient. But we did the other tests, ZN stain and CBNAT, which were not suggestive for the same. So probably this case might turn out a cardiology consult, mostly, because we then have the next aliquot. The previous reports from 1 month back showed some record or possibility of the patient having bilateral adnexal mass. So an ultrasound whole abdomen was done. The whole of the study was normal except for ovaries. The ovaries were bulky and solid looking, measuring approximately 39 centimeters cc in volume on the right side and 37 in volume on left side. That is, we had bilateral bulky ovaries. Even an MRI lower abdomen with contrast was repeated to confirm the findings. Both the ovaries were bulky and solid looking, showing intense homogeneous enhancement. Right ovary was 4.7 by 3.5 centimeter, and left ovary was 5.2 by 3.6 centimeter in size. Again, bilateral solid ovarian masses. So CA125 was sent, which was 126.9, the normal value of which is 0 to 35. CA125 was raised. So what we did next, we got a biopsy of the left adnexal mass. The true cut biopsy was taken, which showed presence of a tumor, with tumor cells arranged in nests and clusters and nodules separated by septae. Individual cells had eccentrically placed hyperchromatic nuclei pushed to the periphery with an abundant amount of vacuolated cytoplasm, giving a signet ring appearance. The tumor was infiltrating the ovarian parenchyma and lymphovascular invasion was noted. Residual ovary showed corpus albicans. Therefore, the impression was made for signet ring cell carcinoma. And after that, we also have the report of pericardial fluid for malignant cells. We also sent that to confirm if the pericardial fluid was indeed a metastasis. So the smears showed clusters of atypical vacuolated cells having nuclear hyperchromasia, irregular nuclear contours, eccentric nuclei, inconspicuous nucleoli, and moderate amount of cytoplasm, again giving a signet ring appearance. Background showed in neutrophils, lymphocytes, foamy macrophages, reactive mesothelial cells, and RBCs. So the impression was positive for malignancy, and they were indeed metastatic carcinomatous deposits. I'll stop here, and we have one more aliquot after this.
Yeah, so Dr.
So
Ryan, I think you came to the diagnosis or you hinted to it like a little earlier itself that it's the whole thing is probably a systemic issue and it's having the manifestation in the pleural space as well as the pericardial space. And now when you see the studies showing signet ring cells largely, which organ do you thinking of what the primary is? And we recently had the NEJM article being published about metastatic disease, which is unknown primary. How do you proceed from your?
yeah. So yeah, first of all, this is an awful diagnosis for a young person. And I feel very badly for this woman that this is what it turned out to be and not some sort of viral inflammatory thing or something like that. I fully admit to not being an expert in signet ring cells of the ovaries, but my understanding is that they are often found as part of Kruckenberg's tumor in gastric CA. But has she had a workup for gastric CA, or is there any reason to suspect gastric CA?
We have one more aliquot.
Oh, okay. All right. So if that's where you're headed, this is now we're getting into like almost a board question kind of thing of a young woman with bilaterally enlarged ovaries, and they show signet ring cells, and often, unfortunately, the tumor is not in the ovaries, it's in the stomach, and it has spread to the ovaries. And ovarian cancers are famous for reasons I've never totally understood, causing swelling all over the body, so can present with ascites and pleural effusion and pericardial effusion. So now this is sort of fitting together as, someone who unfortunately may have had a gastric cancer, or if there's something else that can cause signet ring cells that I don't know, that may be the case, that has now caused her to develop tumors in her ovaries, and that's spread, and it's spread to her pleura and spread to her pericardium, and that's giving her all these symptoms. Could also fit, I suppose, with the menstrual irregularities. I would expect menses to stop when you have ovaries that are filled with cancer cells, but I mean, I suppose that process could involve some irregular bleeding or heavy bleeding or something which led to the history you got about irregular menstrual bleeding and anemia.
Wonderful points. The second aliquot where I told about the HPI was like 2 or 3 days after I was asking the relatives again and again, how did the symptoms start? So that was when they told me about that. And regarding the next aliquot, we also got an ultrasound chest and bilateral breast. It showed significant left septated pleural effusion. So no significant abnormality was detected in bilateral breast. Now we also got the immunohistochemistry for the left adnexal mass, which had significant reports. That is, CDX2 was strong nuclear positive in tumor cells. Cytokeratin 7 was focal cytoplasmic positive. Cytokeratin 20 was again positive. PAX8 was negative. Beta-catenin was negative. And STAT-B2 was negative as well. So this immunohistochemistry report favored the presence of a non-colorectal gastrointestinal primary tumor, and the impression was made of a metastatic signet ring adenocarcinoma with upper GI or pancreatobiliary in origin. Then we also got a CEA level, which was 3.08. Which is around 0 to 5 in non-smoker patient normal. CA 19.9 was 7,880. The normal value is 0 to 35, which was significantly raised. So the final diagnosis was made of a Kruckenberg tumor, that is metastatic signet ring cell carcinoma from a gastrointestinal primary to the ovary with pericardial and pleural metastasis. Something that I learned from this case is that it is of utmost importance to actually differentiate a primary ovarian tumor with a Krukenberg tumor because of the difference in how we treat it and how the prognosis of it is. So regarding the immunohistochemistry report, in
Anmol,
that.
can I interrupt you for 1 second before we learn from about your teaching learning points from tree managing the patient? Can I just ask Dr. Ryan for his teaching or his takeaway so far? Is that okay with you?
Yeah. So a lot of times systemic disorders come to attention once they affect the lungs or the heart. Unfortunately, that's just the way it goes. People are willing to let symptoms go that are mild, but then when they have shortness of breath or chest pain, that's what brings them to attention. And this is sort of the point I was making from the beginning. Like a lot of people come in and it sounds like heart failure, or it sounds like pericardial effusion, and those things can be there and you can't ignore them. They're life-threatening things. But, a lot of things early on this case said there's more than just something going on with the heart. The biggest one being her age. Someone who's 70 and comes in with heart symptoms, you say, well, maybe they've started to develop a heart condition. Someone who's 37 really shouldn't have that unless there's something very unusual going on. So, I think the workup led in a pretty typical manner. There was a lot of attention paid to the lungs and the heart, as is normal. But then, further testing showed, the bilateral enlarged ovaries, that changes everything. Now you've got something going on, and any cancer that causes both ovaries to enlarge is not going to be a primary ovarian cancer. That's almost always going to be something spread to the ovaries, because you won't simultaneously get a primary ovarian cancer that develops on both sides at the same time. So once you see that, you kind of know what's going on. And a really unfortunate diagnosis for this poor woman. But good that you got to the bottom of it, because it sounds like, as is typical for these cases, she bounced through the healthcare system, with various complaints, getting tested here and tested there, and needed someone to put it all together.
So from my learning from my experience of managing patients with malignant pleural effusion or pericardial effusion, they are recurrent. And so at this point, is the pigtail going to be the definitive treatment management for her? Or how would you think of it? Or would you think of additions or pericardiectomy? Or how would you?
I mean, so she needs a multidisciplinary approach about what's next, but assuming she's going to get some kind of chemo or systemic therapy, most people will have a pericardial window placed. So, this is basically a hole in the pericardium so that it can't accumulate fluid. Any fluid that attempts to build up around the heart will drain into the chest and go down into the abdomen. So I think at this point in time, now that you're dealing with a malignant pericardial effusion, she probably would get a window placed.
Thanks a lot for this insight, Dr. Ryan.
Yeah.
Anmol, it's an amazing case, and it must have been a very hard diagnosis to share with the patient. And like you mentioned, it's important to find out if the ovaries were having the primary or if they were having the metastasis as well. If you didn't mind, would you be able to share just about 2, 3 points, main important takeaways which you thought, which you learned while taking care of the patient?
Yes, we actually involved the oncology team, and the plan was to get the endoscopy or, if needed, colonoscopy to assess where the primary is once the patient got stable. But the patient came from a very different background, so it was very difficult for them to digest this diagnosis, having 3 children. So they were too stunned for that, and they did not wish to continue further treatment. The plan was to get systemic chemotherapy for the patient. We just saw this patient 15 days back, and they just took discharge, and the patient has been lost to follow-up. So that has been the story for this patient. But the main point from this case was just diagnosing that we have bilateral ovarian, just as you said, bilateral ovarian masses, that must have a primary somewhere else, and the most common site of which is gastric. We can have it from other sites as well, like colon, appendix, breast. But this patient, we mostly think that it could be gastrointestinal or pancreatic biliary tract, which was involved, which was the primary source for it. Other than that, I think that was pretty much the case. I hope we had. I hope I could make worth of your time. And this was more of a cardiology consult rather than a primary cardiology case. But it was great learning from you. Thank you.
Oh, you're
Thanks a
welcome.
lot.
Yeah, I mean, this is a very interesting case. It is too bad she's lost to follow-up, although the prognosis for gastric CA is very poor. Metastatic gastric cancer is very poor. And my understanding is gastric cancer is usually diagnosed after it's metastatic, unfortunately. So even had she elected to stay and undergo full treatment, the chance for long-term survival is low. I don't know enough about why it's so hard to treat compared to some other cancers, but it definitely is. So you know, I used to do these morning reports all the time at UConn when I taught there, and I would always come out feeling the way I feel now, like this is such a fascinating, interesting case, but unfortunately, the poor patient, it's just a really grim diagnosis, and that's often the way it goes. Luckily, most people with shortness of breath do not have a Krukenberg tumor. So it's not high on my differential when someone tells me they're short of breath. So hopefully you won't be diagnosing this over and over and over and over again. But definitely something good to think about. Very, very interesting. Did the pigmentation of the skin ever get sorted out? Someone put it in the chat, I mean, tumors can make ACTH. I think of that as a lung cancer thing, not other cancers, but who knows, maybe some other cancers can. But did that ever get sorted out, or was that just a weird piece of history from the patient?
We did not get the endocrinology evaluated, and that could be probably just a layman language kind of a thing. When I was trying to understand what was going on, it just said that the symptoms started from this point. This was the thing that they wanted to get evaluated outside. That why is she having menstrual irregularities, and then probably I believe that it was all due to anemia only. And regarding the when the patient was discharged, we took out the pigtail catheter, and nothing was done for the pericardial recurrent pericardial effusion possibility. Pleural effusion got repeated again, so there is possibility that pericardial effusion would be recurrent as well. The plan could have been to insert a pericardial window, but we could not do anything much for the patient.
Yeah, and I mean, it took a couple months for the effusion to get big enough to bring her in, and you've drained it now. So it may not come back right away. She may be fine for a long time with that fluid drain for at least a month or more. But I mean, I'm torn about people like this. I have seen people with gastric cancer try to get everything done. They get the pericardial window, they have chemotherapy, the treatments can be brutal, and they can end up dying from the tumor anyway. So I wonder if they would have been better off taking a hospice sort of approach from the beginning. On the other hand, once in a while there are cures. So, this is the part of medicine where it's helpful if you know your patients and you can talk to them about what their goals are. I think most young people will try to treat aggressively, especially someone with young children. She would try everything, and we would try everything to get her a cure if we could, or help her to live as long as possible with this.
Okay. Thanks a lot, Dr.
I
Ryan, for your input. Yes, Anmol, do you have something to say?
I just had a question. So she was just referred to the cardiology emergency in view of cardiac tamponade. So that is what the consult was about. We usually see some cases with cardiac tamponade. Once I saw a case of type AB thymoma presenting as cardiac tamponade, though it is not known to metastasize. Do you have, by your experience, what kind of cases you have seen presenting as cardiac tamponade?
Yeah, most of the tamponade I've seen is tumor related. It's someone who has metastases to the pericardium and the fluid accumulates and it builds up and causes tamponade. I'm glad you mentioned that though, actually, because we can talk briefly about tamponade. So tamponade is really a clinical diagnosis. I mean, echocardiography can support the diagnosis when you see collapse of the chambers, but you really need to demonstrate a pulsus paradoxus. And I don't know, did anyone ever attempt to measure one or anything like that? She definitely had low voltage on her EKG, but you can see that without, that doesn't mean tamponade, that just means an effusion. You can even see electrical ultrasounds without tamponade, just from an effusion. So the EKG is not going to tell you tamponade or no. The echocardiogram has those findings that suggest tamponade, but really it's a physiologic phenomenon of a decrease in the systolic pressure, that goes with with the effusion. So you really have to check for that. And I wonder if anyone did back when she came in.
So when she came in, I was not there present. They must have checked it. I actually work alongside cardiology fellows, and so we have a focus echo machine all the time. So they must have just focused the patient, and probably somebody would have checked.
Yeah. I mean, even if she didn't have pulsus paradoxus, it would be hard to not drain that effusion when she's tachycardic and all that. So she probably had an indication for a pericardiocentesis no matter what. But it would be interesting to see if she had pulsus paradoxus. Do you guys know how to measure it? It's always a fun thing to review. There's so many bad ways to measure pulsus paradoxus. Anybody have a way they're willing to share? You can even share in the chat and I'll read it and take responsibility if it's wrong.
I know one way.
What?
We can insert an arterial line, and we can look at the telemetry monitoring to to see.
That's a great, I'm actually really glad you said that. So when I was a fellow, I was called to the ICU for an emergency pericardiocentesis for tamponade. And I went in and the residents were trying to measure the blood pressure to determine it. And they didn't realize the patient had an A line. And so when I walked in the room, I said, your patient does not have tamponade. And they said, how can you know? And I pointed to the screen and I said, I can see the blood pressure. And it's not going up and down with the respiratory cycle. So I know that they don't have pulsus paradoxus. So an A line is a great way to do it. If you have an A line, you see how the systolic pressure goes up and down with the respiratory cycle. And, a change of more than 20 or so is very high. But a really good trick for how to screen for pulsus paradoxus. So most of the time, people who have pericardial effusions do not have a pulsus paradoxus because it's only a minority of patients with a pericardial effusion that have tamponade. So really, what you want is a quick screening test for tamponade. So the way I do it, which was taught to me by a great hospitalist attending of mine, is that I inflate the blood pressure cuff and I listen to the patient. Remember, you're checking for changes in blood pressure during the normal respiratory cycle. So you don't ask them to hold their breath or breathe deeply. You want them to be breathing completely normal. And you want to see what happens to the systolic pressure during the respiratory cycle. So you pump the pressure all the way up till you hear no corticoff sounds and you let it slowly come down. And as it comes down, you will hear a point where you hear intermittent corticoff sounds. So you hear bump, 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 and then it goes away. And then you hear bump, bump, bump. Okay. Then you lower it further until you hear all the corticoff sounds throughout the respiratory cycle. So bump, 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 bump. At that point, if you pump it 10 millimeters higher and you hear no sounds, there is no pulsus paradoxus. And this is the easiest way to screen for it, okay? Because the pulsus paradoxus is the difference between those 2 points, where you hear the sounds intermittently and when you hear them constantly. And this may be a confusing thing for me to explain by Zoom. It's easier to explain at the bedside with an actual patient, but hopefully you're following me. But a quick screening way is to identify that one easy to identify point in the respiratory cycle where you hear all the corticoff sounds, and then pump the cuff up 10 millimeters higher. And if you hear nothing, there can be no pulsus paradoxus. You've just ruled it out. And that's helpful when you're in the ER and your attending says, go check if this patient has a pulsus. You can quickly say, no, they don't, by using that way.
Thanks a lot for that tip, Dr. Ryan. And the only time I had to do a pericardiocentesis was in my first day of my intern year and in India. And then I'm very sure I did it the wrong way. But then my attendee was there near me, and then he asked me to go for it. And he was like, he was a fellow too. So I think both of us were still learning. It was to go at the apex of the arch and then try draining. And it went well and the patient survived. But how do you recommend, or how is it recommended that we do the pericardiocentesis? Is it through the sphenoid or with the POCUS, or just leave it for the IR to do it?
So in the US, pericardiocentesis is usually done by cardiologists, interventional cardiologists in the cath lab using fluoroscopy. And we usually use the subxiphoid approach. You do sometimes have to do them emergently at the bedside. This is very rare. It's usually as a last-ditch effort in someone who has had CPR for 30 minutes, and you just want to do this to exclude tamponade as a cause of their ongoing, cardiac arrest. But again, we use the subxiphoid approach, and it's basically very straight in and pulling back until you hopefully see clear brown fluid, not blood. If you see blood, it's usually bad. It usually means you've hit a gastric artery or something like that. But again, in the US, unless the patient's completely unstable, they usually go to the cath lab under monitored conditions so we can use the fluoroscope. Also, in the cath lab, you have tools like the pigtail catheter you had in your x-ray. You can insert and measure the pericardial pressure and put in a drain and leave the drain in place and things like this.
Thanks a lot for that, Dr. Ryan. And just for the sake of time, Vinny, are you willing to share your main two takeaways from the whole session?
Yeah, absolutely. So I think that the main point of the whole session is to have a broad differential diagnosis on a patient who comes with shortness of breath. You need to investigate the most concerning features of the case at a first glance, and then you can proceed with some more advanced labs and imaging. And in the end, the MRI revealed the patient to has a large bilateral ovary masses. It was indicated in the biopsy. Unfortunately, the biopsy revealed a Krukenberg tumor, and then we could correlate with the metastatic lung features, and also with the pericardial effusion diagnosis. So by that, you can trial what would be the best approach to like doing the comfort care or doing whatever should be done for the patient in the future. Thank you so much, Dr. Ryan. Thank you, Animal. It was an outstanding case.
Thanks a
That
lot,
was a great.
everyone, for signing in, and also just for the respecting everyone's time. I'm going to just say thanks, Dr. Ryan, and thanks, Anmol, for presenting the case, and I'm going to sign us off. Is that okay?
I'll just have